fine, but please don't put them anywhere public without, don't want them on social media. But you're very welcome to take them yourself, and likewise with people. So, you know, some people may not want to be in the public. Hopefully I'm the first one on here. The other thing is, you will, although the acoustics in this room are quite good, and you don't really need the mic to be heard, we do need to use the mic because we're recording the sessions. So if you want to ask a question, please put your hand up, we'll give you the mic, and then you have permission, if you like, permission to talk. So, okay, I'll go over here. Second? That's fine, yep, yep. No, which is basically the idea that that it's believed that caesarean section is always protective, and that being sued can generate negative publicity, resulting in healthcare providers providing a caesarean section for professional protection sometimes, rather than always to benefit the mother and baby. And this is a phenomenon we have seen all around the world, all around the world. It's not specific to any one country, and it's not specific to systems that are privatized either. So we have this happening in the United Kingdom. Our caesarean section rate is doing this. Socioeconomics, or necessarily to do with case mix. There's something else going on here. Oh, I've got a magic turner over. It doesn't work. Only a pointer. Oh, it's only a pointer. Okay. Oh, okay. Right. So we have come at this with a couple of theoretical perspectives. The first one is the theory of reasoned action or behavioral change. It's called many different things. But the idea is that people tend to do things that are easy, give them a benefit, and that caesareans quite liberally, that generally speaking it's what is expected of you and it's easy to do, and you get some kind of benefit, either social or financial, you're going to do more caesarean sections. On the other hand, if you work in an institution where it's easy, normal, and gives you a benefit to do more vaginal births, you're likely to do more vaginal births. Now, that doesn't change the fact that hopefully you will always do a caesarean. Well, if a woman needs a caesarean section, she must have one. But we're talking about the rates that are above and beyond the, that necessity. So the second one is behavioural.
Education, which I'll hear more about in the presentation. Red is very low, green is very high, and as I'm sure you all know, Taliban province is in the dark green, very high level. And this is the illustration of the importance here. So this is maternal mortality, and this is caring rates. Now, Taliban does have a low maternal mortality with a very high caesarean section rate, but actually, carers with a lower maternal mortality for a much lower caesarean section rate. Obviously, if you get below 10-15%, you get high rates, that's bad. You don't want them. Again, I'm not saying here that there are absolute rates that we should stick with, but the evidence to show that there is a point at which the benefits begin to translate to losses, particularly if there's a long-term consequence for high rates of caesarean section in the population now. And we do notice this tendency beginning to happen in India of a fear of litigation generally in medicine. It's much, much worse in the many countries of the world, not so prevalently, but it is still an issue. I don't know what obstetricians in the room think, but certainly when we have other meetings with obstetricians, they have said quite clearly that fear of persuasion is an issue for them. Also, fear of violence from the family, pressure. So not just litigation.
If things go wrong. So our intention is to try and reorientate from the normative assumption that intervention is always beneficial, although sometimes it is, but not always, and to look at this in the grounds of human rights, evidence and amelioration. And our objectives and outcomes are to influence knowledge amongst lawyers. This project is focused on lawyers, although we have ended up, obviously, having a lot of conversation with doctors and with women's advocates. So knowledge and attitudes towards human rights of women and the fetus, intended future attitudes and behaviours and decision making, and the feasibility, acceptability and usability of the education tool that we want to develop, which you're hopefully going to help us with a bit today. We want an evidence-based re-judge programme, either delivered face-to-face or online or a mixture of both at the end of this process, and a community of practice where people can share good practice between and amongst themselves. This is what we originally intended to do, a series of reviews, a toolkit, various things. In the event, because of COVID and other reasons, we have only met for the first time yesterday, our project. We've been going for nearly 2 years. So it's been very interesting and not always straightforward to manage a big project like this with so many partners online. So we had to change some things. But we have done a series of interviews, which you'll hear about. We have done a series of workshops, which you'll hear about, a survey, and we're in the process of developing the toolkit. So our stakeholder group has been critical. Some people in this room are members of that stakeholder group, and that group comprises legal profession, clinical staff, policymakers, service users, public health, education and behavioural change stakeholders from within and without India, and they've met online regularly and have been incredibly helpful. And then the interviews and workshops have generally involved lawyers and doctors, but also women's rights advocates and social science experts. So so far, this is where we are. So you're just about to hear from Anna Pilar about the scoping reviews. The interviews are done. The workshops are done. We've done some mapping of undergraduate legal courses in the UK to see how far human rights and consent and reproductive rights issues, gender issues, are in that curriculum. And then we want to do the same in India. And the before and after survey we've been doing has been tested. So I'm going to hand over immediately to Anna Pilar to tell you about the reviews. And after Anna Pilar, there's a recorded session from our legal expert, Professor of Law in Canada, Joanna Erdman, who's going to talk about the legal reviews she's been doing. This is...
Yes. Perfect. Good morning, everybody. My name is Ana Pilar Beltrán, and I'm a medical officer in the World Health Organization in Geneva, and I'm going to talk 5 minutes about the scoping review that Sue mentioned before. So the first thing in this study, in this project, we wanted to map the drivers or the factors that affected the fear of the fear of litigation. And what we did is this scoping review, which is actually a methodology that we use in science to identify and collect all the evidence available in the literature and summarize it in a meaningful way. So that's all we did. And then using the WHO principles for the adoption of a behavioral perspective, of a behavioral science perspective into public health, we map the factors that we found and consolidated in this graph. So here, this is not a framework, but it's a graph, it's a mapping of the factors that drive, the behavioral factors that drive fear of litigations. So we found the cognitive drivers, social drivers, and environmental drivers. And we posit that these are part of the factors that increase fear of litigation and subsequently increasing the use of cesarean section, and within this of unnecessary cesarean section. So we're going to talk about these factors throughout the morning, but I'm going to quickly go through each of them and define them for you. I'll start with the cognitive drivers. This is a busy slide, but I'll go, we have in the left-hand column, we have the constructs. So each of the constructs that build the dimension of cognitive driver. I'll go through the definition with you, so you don't need to read the second column. And just to illustrate the number of countries that contributed to that construct, the countries are shown for you on the right-hand column. So here in the cognitive drivers, we have what we call the availability bias. This is how doctors and everybody, not just doctors, but in this case, doctors and healthcare providers, make judgments on probabilities, not on the basis of scientific and statistical significant evidence, but on the basis of availability or easy access of data in their brains, which tends to be emotionally charged or very or late or very close in time. So this is called availability bias. The next one we have is the ambiguity aversion. We like certainty. We don't deal good with uncertainty. This is doctors and mothers, everybody. So we tend to avoid uncertainty to the extent that is possible. The third one is the relative risk bias. And this is the bias that makes us more scary when we are presented the information in terms of relative risk versus absolute risk. Even if the risk is increased from 1 to 2, from 1 to 2,000 every 1,000, you know, that's a 100% increase, which is very scary, but it's not so scary if you think of, okay, just is one more. And doctors, when they are presented with relative risk, they tend to be more scared, and they have wind up thinking that in many cases cesarean section is safer than vaginal birth. Then there is also something probably very well known for all of us, the commission bias versus the omission bias. So as healthcare providers, we tend to like action versus omission. We are wired to do things, not to stay expectant. And then the last one is the loss aversion bias, by which, you know, the pain of loss is psychologically more powerful than the pleasure that the gain give us. So we are much more conservative to avoid loss than to make a gain if we have to choose between the two of them. So this is in terms of the cognitive bias. If we move to the social drivers, here we have 4 constructs. We have found 4 constructs. Patient pressure. So pregnant women and families are pressuring, according to the healthcare providers, are pressuring more and more to have a cesarean section. And this is what we had been calling cesarean section on demand or maternal request. The second construct, the social norms. Interestingly, cesarean section is becoming more and more like the new normal, the new modern way, which is the accepted way. And in those contexts, trying to promote a vaginal delivery, doctors feel that is dangerous, and they try to run away from it. And the third construct has to do with the blame culture. Obviously, we are more and more building cultures where there is a very low tolerance for imperfection, or for errors, or for outcomes that are not perfect. And that is harder and harder be handled by doctors, because doctors cannot promise perfection. Problems and complications exist in both cases, both vaginal delivery and cesarean section. But the perception is that vaginal delivery has more chances of having a problem. And then the last dimension are the environmental drivers. Here we have 4 constructs. Doctors talk about the legal environment, and they talk about this environment, which are constituted by tort laws, court system, and other evidence around it, and the expert witnesses. We also read a lot about the expert witnesses and how this environment is not supportive. They talk about the randomness of the system and how the decisions are made on the basis of emotional criteria. They rely on emotional criteria instead of on evidence. The second construct is the malpractice insured environment. I don't think that requires any explanation. Then the medical practice environment. Here again, healthcare providers talk about the little support that they get within their hospital administration from a midwife. Our society has spent more time on teaching the process of sewing rather than introducing the labor to the general public. Your reputation is important. No one will give you a gold medal for a VBAC, a vaginal birth after a cesarean section. A VBAC rate of 95% if you make one single mistake. And lastly, one that really, really summarizes the whole storm that we're going through. It's almost like the perfect storm. You're going to pay me more. I get to worry less. You're not going to sue me. I'll be done in an hour. Thank you very much.
Of rejudge.co.uk, and it's up and you can check it as well. So we are not going to put all the presentations into the bag. Thank you.
I also say you've probably got some questions from what's come up, or maybe some issues, or maybe even some contentions. Write them down, save them, don't forget them, and we'll bring them all together because we have hopefully a good half an hour at the end before we move on to the next exercise for you all to put your thoughts into the mix. So please don't forget what you want to say as we move forward.
Hi everyone. I'm sorry I couldn't join you today. I'm in Santiago, Chile, where yesterday we witnessed the rejection of a new constitution. This was a constitution that would have expressly protected sexual and reproductive rights, ensuring to everyone the conditions for a voluntary and protected childbirth and maternity. So today there is some sadness, but continued hope for the future. My name is Joanna Ergman, and I'm a professor of law at Dalhousie University in Halifax, Canada, and I contributed the legal review to the Rejudge project with the support of law students Julia Borges and Alessandra Feldstein. This review was guided by an understanding that legal actors, lawyers, and judges act with respect to the law. Their knowledge, beliefs, and attitudes shape the law, and thus also legal risk for health professionals. But the law also informs the knowledge, beliefs, and attitudes of these actors. So if you want to change the behavior of legal actors by education, or you want to make recommendations for policymakers, you must understand the law in relation to obstetric care, specifically labor and delivery. And this was exactly the objective for our review of obstetric litigation. This is also called maternity or birth injury litigation. It's an area of law that broadly includes medical malpractice claims under tort or criminal law, as well as claims of administrative breach under professional codes. These claims may be brought to and are decided by various institutions, including courts of law, but also compensation schemes and medical councils. So our specific objective for this review was to understand if and how cesarean section figures as a preventative or protective intervention within obstetric litigation. But our more general objective was to understand the nature of legal risk and reasoning within this field. That is, to understand fear of litigation in obstetric practice from the perspective of the law rather than the health professions. We had two distinct projects in the legal review, and I'll briefly describe each. The first project was a mapping exercise, namely to map all relevant English language legal research or literatures in obstetric litigation globally. Based on our mapping, we identified four basic types of legal research. The first two types are primary research or case law. These were one, closed claim reviews, which involve an assessment of a body of legal claims, often from a single institutional source, such as an insurance scheme or a medical counsel. The second type of research was primary case analysis. This involves an in-depth analysis of a single case with attention to the legal issues or reasoning, often within a judgment. So, for example, one study of this kind of research investigated how judges in individual cases have dealt with specific aspects that were identified as contentious or controversial in a UK closed claim review. Now, much of this primary case analysis focuses on the Canadian, US, and UK context. In the mapping, we also identified two types of secondary research. The first is medical legal research, which involves medical professionals and lawyers writing about specific contentious aspects of obstetric litigation. So for example, this literature included writing by medical professionals who were writing on the law or legal standards and outcomes, specifically those that departed from medical knowledge or evidence-based care. And they were doing so because they were trying to inform these legal standards of care by citation to consensus statements or other professional standards. Within this literature, we also had debates among, for example, defense lawyers about legal standards, again, on causation, especially as related to birth injury. This literature, again, was very diverse. We had professional guidance for healthcare interventions and other practices, namely aspects of documentation to reduce legal risk. And last, this medical legal scholarship also addressed general themes within obstetric litigation, such as risk or interventionist culture, themes that very closely aligned with our other disciplinary scoping review. The fourth body of literature that we identified in the mapping exercise was empirical legal scholarship, and this involved empirical assessments of knowledge or attitudes towards litigation or experiences with the litigation process itself, as well as the impact of litigation on healthcare practices. For each of these types of research, I described the nature of the research, and I collected exemplary resources for each type of research. I then suggested ideas, issues, and trends within each of the body of research. And last, I suggested potential uses of this research for different components of the ReJudge project. I have to say that this field mapping was extraordinarily interesting. I shared it with the team, and indeed the field mapping proved invaluable to shaping other activities and components of the project, especially the interviews and workshops from a legal perspective. As a second project in the legal review, we conducted a thematic analysis of the closed claim reviews for publication. As a reminder, closed claim reviews are assessments of a body of legal claims related to obstetric care. These reviews differ in data sources and data extracted, but collectively they provide a rich source of material on the major clinical and legal issues involved in obstetric litigation from a diversity of legal processes and institutions. We analyzed 51 such reviews. These included obstetric-specific reviews, but also pan-specialty reviews. The reviews were undertaken from 1989 to 2020, but most of the reviews were within the last 10 years. And they were from 15 different countries across the world, with a few being multi-jurisdictional reviews. In our analysis, we compared various features across the closed claim reviews, including the many features that you see listed here, the nature of the claims, the primary clinical injuries that were involved, the kinds of clinical practices or the substandard care that were underlying the injuries, the primary legal issues in these cases, the types of evidence that were used. We also took note of any comments on the legal environment or the social context. And then what we did in this project was analyze these features against the behavioral constructs that were associated with fear of litigation as identified in the other scoping review. And the findings of this legal research were quite striking. Namely, many of the behavioral constructs that were identified in the very different disciplinary scoping review were also reflected in the legal rationality and the legal culture of obstetric litigation. So if I can put this idea plainly, we found that these behavioral constructs were reflected in the very law itself. In brief illustration, I'll give a few examples. We found that liability, for example, tends to attach to provider inaction rather than action. In other words, substandard care was often described as a failure to diagnose, a failure to manage care, a failure to intervene, a failure of clinical knowledge, a failure to follow protocol, a failure to follow up. In other words, again, we see these legal ideas reflecting a commission or intervention bias. We also found that the degree or nature of the injury, rather than evidence of a breach of standard of care, tended to determine liability. This, again, reflected motivational reasoning. That is, legal actors and liability tended to follow a motivation to compensate families, especially in the event of severe or catastrophic injury, rather than formal legal reasoning. We found that expectations of labor and delivery as a happy event created a bias or inference that adverse events must have resulted from substandard care. Again, this reflects a construct of cognitive bias among legal decision makers. We found that causation was the most contentious litigation issue, and therefore that ambiguity as to whether or not an action did or did not cause injury was especially important in obstetric litigation, and again, as especially related to severe injury, brain injury, or birth asphyxia. Last, we found that the blame was more often attributed in these cases to human error than system failure, and that obstetricians, rather than any other member of the healthcare team, were most often blamed. This set of findings relate to the construct of a blame culture, and this is not the only culture present in the legal reasoning. We also found evidence of risk culture, specifically where there was an assumption in these legal cases that most obstetric risk can be prevented or managed. For example, there was a common reference more than once in the reviews to a comparison of aviation metaphors, or how to make flying safe in the same way as you might make childbirth safe. The last thing I'll note here in the review was this overwhelming sense that good documentation above all other forms of evidence was the most important litigation asset for providers. And this included documentation around patient communication on expectations, awareness, and information. Now, as far as we know, this is the first effort to integrate behavioral constructs on fear of litigation with legal research on risk and liability in obstetric litigation. It's quite innovative research, and we very much look forward to publishing it. Thanks so much, and have a great meeting.
So we're now going to move into some of our data from the project. So I think Sunny and Sham are going to present the findings from the interviews that we did. Again, I think some of you in this room were part of those interviews probably. And we'll follow that on with some data on the survey and the workshops.
Morning, everyone. I'll just go through very quickly the sort of just a fact-finding or fact-presenting exercise in terms of the number of interviews and things which we found from these interviews, and tried putting them into perspective in order to make sure that it reflects what was done in the scoping as well. So given that, we did about 19 reviews. Each interview lasted about 19 interviews. Each interview lasted about 45 to 60 minutes. And because of the regulations surrounding COVID, etc., we had to do it virtually. And we had developed an in-depth interview guide and used that guide in order to pilot it and then test it, as well as then use it. Specifically, we were looking at different drivers around birth-related litigation, not especially cesarean sections, but birth-related litigation. And then we looked at cesarean sections before, during, and after related events in order to see whether that sort of drives any issues related to litigation. all the consent procedures, etc., were taken, and a standard analysis, etc., in terms of anonymization, data security was thing. And we found key behavioral drivers from the analysis. What I'll present now is a very brief profile of who the interviewees were and what categories they belong to, just to let you know that this was a sort of heterogeneous group of people whom we interviewed, including obstetricians, pure obstetricians in practice, as well as obstetricians who were also well versed with the legal, they were also legal experts in their own right, and they were also doing a lot of family counseling in addition to obstetrics. Then nurses, midwives, childbirth educators, etc. Social behavioral scientists, social sciences, humanities perspective, etc. Then we also looked at lawyers and advocates and activists, basically looking at human rights activists or birth activists, etc. So this is the sort of broad distribution of whom we interviewed, and at least there were 26 years of experience in terms of what they were doing, as well as the average age of the interviewees, or the median age, was 52. So what I'm going to present is blocks of what the constructs which emerged. And I've tried to sort of put a small example or try to explain what it is. I think it more or less sort of superimposes on what was presented earlier in terms of the outcome ambiguity or aversion bias, in terms of saying why take the risk. That's the sort of thing which came out also from the interviews. Blame culture. In addition to blame culture of what Joanna or Anna presented with respect to obstetricians being blamed part of the game, many of the activists also felt, and also mothers who were also part of the group but also had cesarean sections themselves, said that if there is a outcome in addition to not having a baby of an expected gender, the mother is blamed. So blame culture extends both ways in terms of both the provider as well as the end user in terms of the services. To the extent that somebody said if they had done a cesarean section, probably it would have turned out to be a boy. So that's the sort of thing we've got in terms of, that is taking the argument a little too far. Yeah, guidelines, some of the guidelines are very skewed. Just to give you an example, in the state of Telangana, with the increase in the institutional deliveries, I think there is an expectation that as institutional deliveries increase, the number of deliveries where intervention will also happen, like cesareans, will also increase. But there is no evidence to say that. But at the same time, incidentally, because of the cash benefit transfer which happens in the state, the third and the fourth antenatal checkup should happen in a facility which has ultrasound facilities or imaging facilities, which means even if you're normal, if you're detected to be normal, if everything is normal at antenatal care at a primary level, just because the guidelines tell you that you should go to a facility which has, sort of imaging facilities, you go for the third and fourth antenatal care at a facility, you're lost to a system, in the sense there is a tendency towards being forced into undergoing an intervention. That happens, and that is something which was mentioned. It's a systemic issue which I think needs to be looked at very closely as we move towards more than 90% of institutional deliveries. That's something which is, sort of cross-cutting across the thing. Documentation was presented, and I think, like Joanna mentioned, the providers think that good documentation protects them against litigation, and that's very, very important for them. Yesterday we had a discussion, and even refusal of consent was something which was quoted in terms of saying that even if you do that, it will protect you against litigational issues, more than the fear of litigation. Of course, commission bias in terms of saying that it is better to act than to wait. So watchful expectancy with masterly inactivity, as we were taught in our labor rooms, etc., is not something which, which happens here. Loss aversion, which was also found. The legal environment surrounding CS and access to sort of legal help is also something which was found to be very, very limited. You don't know whom to approach, you don't know what to actually present and how you get to it, and invariably it also happens that lawyers depends a lot, with all due respect to our lawyer colleagues. It was told by the lawyers that the lawyers depend on medical professionals for what is called as professional help or expert witnesses, etc. In which case, the fraternity makes sure that they protect each other. So that is also something which was mentioned. And the physical environment in terms of what I mentioned earlier, promoting or, promoting cesarean sections rather than reducing it. Very interestingly, it's become a norm in the sense the peers as enablers of cesarean section. We've had people telling us that, look, my sister had a section, my neighbor has had a section, somebody down the road who I know has had a section. It looks like section is the new normal. So this peer as an enabler in terms of they telling you that, look, it's painless, you can go back to work early, all those rehabilitation issues, cosmetic reasons, etc., which has also permeated semi-rural, urban, semi-urban sort of things as well. The aspects surrounding mothers' rights and choice, this is a very interesting or very difficult issue to decipher or actually to tease out in terms of saying, how far do you go with respect to respecting the woman's or mother's choice? That's where do you go? It's like saying that ultimately you take a decision for me. If you can't bear the pain, you take the decision for me is what happens. And that's probably what we call as the point of weakness which happens. And that is something which came out along with both mother's rights and choice. And all families, especially the mothers-in-law, etc., were very concerned about the child's safety rather than the child's rights in terms of saying, look, in our times we used to have 8 children, 9 children. We used to deliver in the morning and go to work in the afternoon or go to the field. But today, you need only 1 child or 2 children is what is the norm, and we want the safest sort of birth. That child should be safe, right? So that's another thing. In addition to mothers being safe, child being safe is also something which they did say, and the whole aspect related to whether we are providing respectful maternal care. Defensive medicine is something which is emerging, and it has become a big problem with respect to, you make sure that ultimately the mother, as I said, will agree to undertaking intervention just because, you're also protected against issues related to litigation, or nobody's, more than litigation, it's the violence which happens within our facilities these days, because it's a quick sort of solution in terms of making sure at least you get back to somebody whom you think has done something wrong. So that's something which has happened. The issue of prestige, it's very interesting. When the interviews, we got to know that when the mothers, basically the mothers or mothers-in-law feel that if you get a cesarean done for your daughter or daughter-in-law, it means that you have a particular status with, you're looked after very well. You're looked after very well. That's a prestige as a status is something which we also looked at. I talked about legal protection, and the whole issue of reputation being sullied because of a bad outcome is something which they look at, and that is related to defensive medicine as well in terms of what happens. The whole issue of violence, not litigation. I think fear of litigation becomes secondary now. It's the fear of violence, and we look at violence being something which happens quite regularly, and we must have seen it not only with individual providers, but also in public and big private facilities as well with respect to violence. The social norms surrounding childbirth, of course, some of the communities, especially primitive, vulnerable tribal groups, still preferred getting their deliveries done at home. But because of the aspects related to policy, etc., you can't do it, and there are certain social norms in terms of promotion of normal delivery as well. That also emerged. I talked about the legal framework, and last but not the least, in terms of cost. So I'll leave it to Sunny to continue with the summary of the presentation.
Good morning, everyone. In terms of the interviews, the interesting themes which came out of the interviews, which included key stakeholders like lawyers, obstetricians, etc., and even activists and midwives and nurses as well. So most of the individuals feel, or the interview participants feel that out-of-court settlements are better in case there is a litigation involving unnecessary CS or even childbirth for that matter. Most of the mothers or the patient's family doesn't seek legal recourse. The reasons are that legal processes take longer time. They are not aware of how to go about with the legal processes, and they feel the doctor's lobby is too strong to fight. So that's an interesting finding which we gave out. Including obstetricians and lawyers, etc., everyone felt unanimously that clear communication is always better, which includes communication of the provider to the patient, not only the obstetrician but also all the staff within the clinic or hospital. Documentation, as Anna and Professor Sham pointed out, documentation is key because it not only protects the doctors but also the patients or mothers as well. I should say mothers rather than patients. So, and then factors which influence unnecessary CS are basically nuclear families, higher socioeconomic strata, perceive that it is a safe and pain-free method. There are elective CS as well. Doctors' decision to avoid litigation also is the key factor, as pointed out earlier. Interview participants were not aware of court cases involving birthing practices. Although we had, I think, couple of interviewees who had some experience, but majority of them didn't have. Doctor's decision is final is what every mother feels and their families also feel. And there should be more involvement by midwives and nurses as well. Existing policies actually promote CS, as Professor Sham pointed out. Litigation is mainly due to improper communication, not only by the providers but also the staff surrounding it. The awareness about legal processes is also important, not only amongst the families but also amongst providers as well as prosecutors, the police, which involves whom the families actually approach in case of a bad outcome. So they also need to be aware of different regulations surrounding it. And one more important theme is that many of them feel that there should be an arbitrator who can settle or who can mediate and settle the cases between the families and the providers. With this, I will end the presentation. Thank you so much.
Yeah, so about halfway through the presentations, just in case you need to pace yourself here. So what I want to talk about now is I'm going to do a joint kind of two presentations together. One is how we brought these findings so far into the workshops and the survey that we did, and secondly, some of the results of those activities. So we used as a vehicle vignettes. So vignettes are stories that are based on real life, and we constructed some of these stories from some of the interviews we had, and they're used to elicit responses, so emotional responses as well as cognitive responses from people. We picked up on the behavioral drivers, which you've already heard about, so we'll skip that slide. And what we called mental models. This is a slightly different way of looking at the data we already had. So one of the mental models is the belief that cesarean is better. You've heard that already. And I do want to just say what we did have yesterday, which you don't have the benefit of today, is a presentation by Dr. Aziz showing the actual risks and benefits of cesarean section. And I don't know if everybody in this room knows, but while there are some benefits, there are also risks. And what we're beginning to understand is that those risks are beginning to be manifest in the child in the long term. So there are now emerging data that particularly elective cesarean sections, so where there is no labor, there's an increased risk of autoimmune and immune response damage. So an increase of about 20%, for example, in type 1 diabetes in babies born after elective cesarean section. Now, we have to remember that type 1 diabetes the prevalence is very low. So we're not talking about big numbers, but we are talking about a phenomenon which is intriguing. There's also been links between elective cesarean section and asthma, eczema, some leukemias. Again, small numbers, but still there. And there is evidence looking at the epigenome that the myelination of certain genes, particularly those involved in glucose translation, is different in babies born after elective cesarean section, or those where there's been a short labour and elective cesarean and a cesarean section, compared to babies that are born following spontaneous vaginal birth. We don't know what this means, but we do know it's there. So I think the reason this is becoming increasingly of interest nationally to public health people and internationally to public health people is firstly the short-term consequences of cesarean section, but also the long-term consequences for the baby. So we may want to have some conversation about that. Belief that every birth is high risk is part of the issue. The reciprocal relationship between law and the obstetrics. So Joanna referred to that a bit, and this came up very clearly yesterday and also in the workshops. The notion that lawyers require or would benefit from having clear guidelines that are agreed by obstetricians that they can then judge cases against. But also the fact that those guidelines, if created, create the law. So there's a kind of relationship between the two, which requires some unpacking. Weapons of the weak. This came out from some of our data. The idea basically that somebody has to pay, and if I can't afford litigation, I'm going to attack you. This is where the violence comes in. I need to get a response from you. I can't afford the law, so I'm going to either attack you physically or online. Motivation for or against litigation. We've heard that. Motivation for or against compensation. Again, what we found in Joanna found is that lawyers are more likely to compensate if there's obvious damage. So if there's cerebral palsy, for example, even if there's no particular evidence of negligence. Although negligence has to be proven, but you will look for it more if there's a severe outcome. And the other thing that I think is important to put on the table here, because you haven't got those data, is that only 10% of all cerebral palsy cases are caused by labour, as far as we know. So 90% of cerebral palsy is due to an antenatal insult, whereas the assumption, I think, amongst most people is the opposite. Most people think that 90% of cerebral palsy is caused by labour. That doesn't seem to be what the evidence says. Women have no rights or power in society. We do an interview data to the emerging map. We built vignettes and we designed a survey. So this is basically the package that we use for the workshop, the pre-workshop survey, the workshop and the post-workshop survey. In the survey we asked these questions about the risks of cesarean section and the benefits of cesarean section. What are your views about why CS might be high, and what are your views about fear of litigation? So this is an example of the vignette. I would normally not read this out, but I think the text isn't very clear in the back. Can you read the text in the back? You can read it, so I don't need to read it. Okay, I'll let you read it then. So far so good. So for those of you who are not obstetricians, basically what's happening here is that the progress, Nazira's labour progress is beginning to deviate from what is the standard. Not necessarily what's physiological normal, but what is the standard. So there's a suggestion of doing something about it, using a drug to speed the labour up, which I think is quite commonly used in India. And the point about this piece of the vignette is that there is good evidence that if women are upright and mobile and wandering around, the labour progresses better, partly because the fetal head comes down onto the cervix and it releases hormones that help the labour to speed up. So Nazira's request is actually in line with the evidence, but that's not what was actually delivered for her. So basically, Dr. Sultana said, no, getting up and walking around would not make a difference, which is not actually in line with the evidence. But what she did offer is that if the drip is put in, Nazira could sit in a chair, so she wouldn't have to be lying on the bed, which is a good thing. So this last piece relates back to the writing that we talked about, documentation. So she had the conversation, but she didn't write it down. And also there's a question here about how much this was truly free consent, because actually Nazira didn't really want this, but there wasn't really any other, much of an alternative offered to her. So that vignette went on, you know, there were more parts of it, but after each part we asked what people felt about it and got conversation going. And then in the survey we reflected similar things, so we wanted to see before and after if things changed. So in the survey we asked, if you're a doctor, if you were the registrar in this case, what would you have done and why? Would you have done the same as the doctor involved, or would you not? If you're a lawyer and there was a poor outcome and it came to court, what would you focus on if you're the prosecution lawyer? And what would you focus on if you were a defense lawyer? And we wanted to get everybody in the group to hear what everybody else said about this from the view of the other person. And we also, as I say, measured it in the survey. This is the plan of the workshop. It is quite small, so you might not be able to read this, but basically we had a couple of seminars with knowledge, one about legal aspects and one about the implications of cesarean sections. Then we had workshops, 2 separate workshops divided, one with junior staff. That was the intention, that some of you here may have been there. Sorry, one with senior and junior lawyers. No. One with junior doctors, junior lawyers, that's right. And one with senior doctors, senior lawyers. That was the intention. There may have been some mix in the end. And then we had a general, brought everyone together for a discussion. And then people did the survey at the end to see if there was any differences. So what we found, I won't do that one because that's the aim. So there were 14 participants in the workshop and who took part in the survey, and you can see there was a social scientist, obstetricians, so 4 senior obstetricians, 3 senior lawyers, 4 junior obstetricians, and 2 junior lawyers, so quite a mix. And the kind of questions we had, for example, one was what percentage of brain injuries are likely to have occurred before labour, the question I asked you before. Are there ever any grounds to perform a caesarean section for fetal reasons when the mother has the capacity to consent but does not consent, etc. So we asked similar questions to the ones I've just raised for you here. And we asked some questions related to knowledge and attitudes. And basically there were highly variable responses to the questions. And for many, knowledge and attitudes did change following the intervention. We're still doing the analysis of the 3rd survey, so we did it before the workshop immediately, after the workshop immediately, and then about 4 or 5 weeks later. So last week we asked the questions again to see if there was a sustained response. And certainly in the before and after immediate there is a change in a number of the parameters of the survey. But we need to develop it more in line with the interventions over time. Here's some example answers. So can caesarean section be carried out for fetal reasons when the mother has not consented? Most obstetricians said no. Most lawyers said yes, if the doctors feel it's necessary. So that's quite a difference between the lawyers and the obstetricians. What about for maternal reasons when the mother has not consented? And here the answers were more mixed, but many said that caesarean section could be carried out without consent if the mother's life was in danger, which I understand is actually what is the law here. What % of brain injuries leading to cerebral palsy are likely to have occurred before labour and birth? Most answered incorrectly, saying that either 0 or 10%, as I said. So thinking that most was during labour. If it was a negative outcome following vaginal birth, most participants felt the main issue in court would be why was a caesarean section not performed? And of course we've heard from the earlier evidence that's probably correct, a correct answer. The main reason for high caesarean section rate is women's choice, was a statement. Most participants agreed or strongly agreed with this. Now that is completely contrary to the evidence. There was a review, an international review all around the world, looking at the % of caesareans that are due to maternal consent, maternal request, sorry. It's 1% around the world. 10% in China because of the one-child policy and because of wanting to have your baby under auspicious stars, which I suspect might apply a bit in India, but definitely no more than 10%. It may be written in the notes it's women's choice, but that's not the same thing as it being really women's choice. Slow labour is not a risk factor if mother and baby are well, and the majority of participants agreed with this, and we're quite surprised with that. And we do wonder if that translates into real practice, actually. So there are many other answers, but they just seemed quite intriguing. So what we observed from the workshops, a number of things, but one of the questions was from some observations that were made by the observer that took part, who's here in the room, so thank you very much for that. So our guidelines, normative standards from the law perspective, and you can see that basically the idea that what was observed to be in the conversation was that negligence can be confirmed when the guidelines are taken as gold standard, even if the doctor deviates slightly. So this is the other risk of having guidelines that are too rigid, where you can't actually vary for individual women's choice. So it is the tool that law uses to evaluate doctors, but if we don't have any tools, the lawyers can't evaluate doctors. So it's actually where you balance those two extremes, really. So social norms you all know about this, the effects of family pressure. We've asked about this. One of the comments made by one of the doctors in the workshop that was recorded is there are about 7 or 8 family members per patient. They're all present during the process, and many of them are demanding cesarean sections. They will openly say, please do an operation. We want the baby to be healthy. We don't want bad outcomes. Please do the operation. So here is the issue again about women's choice. How far do women actually have choice if they're under this kind of pressure from their families? And equally, how far do the doctors have a choice if they're under this kind of pressure from families? So one of the solutions is a social solution, a community solution to address this belief that women are always going to be safe, and so are babies, if a cesarean is performed. Again, you've heard about this, not fearing negligence, but assault and hospital closures. And hospital closures is interesting, actually, because that's about not necessarily the doctor doing what they want to do, but coming under pressure by their organisation to do things. And if they don't do things the way the organisation wants them to, then it may well be that the organisation feels that they will be blamed by the social media, and therefore the hospital may have to close because they may lose patients. So there's a commercial and interest here as well. Women have no power, so they need medical expertise to confirm pregnancy. The family is always involved and owns the woman's body in a kind of anthropological sense, and mothers alone do not design their birth plan. Observations, round table, more conducive to linear seating. More people participated when questions stimulated anecdotes relating to both the medical and the legal perspectives. We should state the standards and expectations for the conversation in future workshops like that, so mutual respect between the groups as they're engaging. Emphasize the conversation is confidential, and I would make that point again today about the conversation we're going to have. Remind that it's more about learning from different perspectives. So people may say things, and this may happen this afternoon or later on today, that we don't agree with, or we strongly don't agree with. But that doesn't mean we shouldn't still listen to them and respect their point of view, because they may have some interesting things to say beyond that position. So we don't, today and in these workshops, we don't want confrontational arguments. We're looking for respectful debate between ourselves if we can. And everybody's experience is valued, whether you're junior or senior, and we should make sure that we can talk to each other well. So just a final few slides on the acceptability of using the workshops like that. So all the participants said that they would recommend attending the workshop to a colleague. All of them rated the contents as good or excellent, except for one that didn't answer. And positive comments were made, especially in relation to hearing the perspectives of seeing through the eyes of the other professions, because it's very hard to get doctors and lawyers together. We had a real difficulty setting the workshop up because doctors work Monday to Saturday, so we're only free on a Sunday, but lawyers did not want to come to a workshop on a Sunday. So the actual timing of the event was very difficult. So everybody was willing and tried their best. Everybody was vocal, shared their opinions. The seniors more than the juniors, but still they did all share. Again, it was interesting to hear the perspectives of both. And these are all quotes from the survey. And one said, I learned to look at litigation and lawyers differently, less fear, and also to look at cases through a different lens. In terms of the evaluation of the survey itself, the responses were largely positive, even though it was quite a long survey. The workshop was positive, as I said, and the cross-cutting themes that were identified between the interviews, workshops, and surveys were very clear. So basically, the black is strongly agree, and the blue is agree, so you can see for all of them, except for a couple of people who found the survey difficult, so which is why we need to amend it a little bit. So cross-cutting theme 1 is consent as a facilitator of unnecessary caesarean section. This is when consent is taken as soon as the woman walks in the door, in case a caesarean is needed, and then it's always on the table, ready for a caesarean to be done, even if the situation changes and the woman doesn't actually want it. Cross-cutting theme 2, women's choice as a facilitator of unnecessary caesarean section. So this is this notion, as I've just said, which we need to be very careful about, that it's always women's choice driving this. So, for example, one person said, in our culture, they want a particular auspicious time of delivery. Auspicious, we have to honor that also. You cannot say no to them. And then there's a question that one person raised, is this institutionally or otherwise being corrected by institutions? The answer is obviously no. It helps institutions to build patience. So again, there's a kind of relationship between this notion that women's consent is driving things or request. On the other hand, if you're a private institution and you earn more from caesarean sections, then actually it helps you to bring, and also your institution is seen as a good place to have a caesarean section, then it might drive your institution to have more patients, more service users to come. So there's a relationship between the two. The third theme, lack of protection against unnecessary caesarean sections, is the opposite really. No universal guidelines we've already looked at, no proper law dealing with the stage at which a doctor should decide. Nobody ever comes to court and says a caesarean was not necessary. Although this is beginning to happen. Ana Pilar was telling me that in Spain, there are cases beginning to be brought for unnecessary caesarean section. So we should not be complacent about this. The law can work both ways. Particularly if a woman has to have a hysterectomy post-section or whatever. So future research, I think this is my final slide, so coming out of the workshops, but we're going to discuss that today too. How do we protect against consent being used in a way which is not actually based on human rights or gender equality? To what extent can we deal with the social norms that are driving caesarean section? And how can guidance be used in a way that protects rather than damages? So thank you for that. So we have two final videos now. One is about the analysis of legal case, the analysis, of educational curricula in the UK, and the other one is about the Kirkpatrick criteria for education. So there'll be another kind of 10 minutes or so of video, and then, please, we can start the conversation.
Hello, my name's Morgan and I've been working alongside Jill and Sue looking at mapping of UK legal curricula. So our starting point, we started with a website called UCAS, which contains a range of UK universities that's accessible to students and the public. And we filtered our search for UK law schools, so I've put a link here as well if anyone wants to have a look at how UCAS works. We also filtered it for only undergraduate law courses, and in the UK most of them are called LLB courses, but some in this sample are bachelor's courses as well. Not all universities are included on UCAS when we filtered it to the law schools. So what we did was we also added the 24 Russell Group universities, just so we had a bit of variety in our sample. So after looking on UCAS, I went onto the university websites directly, and usually the websites had a section called modules or course structure or learning, something like that. And under these sections, there are a description of the modules and the curriculum. So because our focus was on human rights, consent, gender, and reproductive rights, the only modules that I was interested in was if they included some information on these. And if they did, these data were recorded onto an Excel spreadsheet along with other relevant information, which includes the institution, the course title, the description of the module, and contact details for the course leaders or the head of departments of that institution. And then these data were quantified to show how often these 4 categories were taught in UK law schools. So not all the university websites did provide clear descriptions of the modules. Some only provided module titles, some provided lots of descriptions, and some only provided details on core modules and not optional modules. So this prompted us to email the law schools. And what we did was we sent out a generic email to all the law schools included in our sample. That included a PDF explaining what Rejudge was, and also a table with the relevant categories that we're looking at, and it prompted the course leaders to fill in whether their curriculums included anything in relation to these categories. So from the responses, only relevant ones were incorporated into the spreadsheet. So what I mean by this is some of the course leaders or head of departments replied, but didn't provide anything in specific to childbirth, which is what we're looking at. But if it was related to childbirth, then I would record it into the Excel spreadsheet. Currently, there've only been a few responses. We think this might be because most staff members will be on annual leave with it being summer. But for this reason, we did set a deadline of the 8th of September. So we are still waiting the last minute responses. What we've found so far is that from the 98 universities we've looked at, 24 Russell Group, 74 were non-Russell Group, human rights is the most included topic, and it's presented in 231 modules. Next is reproductive rights, which is included in 88 modules. And then gender, which is present in 50 modules. And the least covered topic is consent, which is only covered in 21 modules. So thinking about how we can apply this to India, the first step would be to find the UCAS equivalent in India. So anywhere where there's a list of Indian law schools, Indian universities, that would be the start. And then using the Excel spreadsheet we've created as a template, or creating your own document to record the data, and then explore the differences between the two, if there is any, and possible reasons for this. So thank you very much for listening, and I'm excited to see what we all find.
Present her work to you today because, she's an undergraduate intern who's very keen to come and work with us for free. And so I'm very pleased that she actually got the opportunity to present to you today, because that will be great for her CV, and she's done a good job. So thank you. Thank you for listening to that one.
Hi everyone. I hope you're having a nice meeting in Hyderabad, and I apologize for not being able to join you in person. My name is Dr. Regina Torloni, and I'm an obstetrician and gynecologist working as a professor at the postgraduate program of evidence-based healthcare at São Paulo Federal University in Brazil. I will be talking very briefly to you about adult education and how to measure the effectiveness of educational interventions. Many doctors in India and in other countries perform cesarean sections that are not medically necessary because of fear of litigation. One of the objectives of the Rejudge project is to develop educational tools to increase the knowledge and change the attitudes of lawyers and judges regarding the real benefits and risks of cesarean sections. When planning a successful educational intervention for adults, it is important to understand how they learn and to think about how we can apply these principles when we are creating the educational intervention. According to the American educator Malcolm Knowles, adult learning is based on 5 assumptions. I will briefly define these assumptions and give some ideas of how they could be applied to the educational intervention that will be created for this project. Adults, differently from children, see themselves as being independent and autonomous. Therefore, the educational intervention should give them maximum autonomy. We should let adults explore the activities on their own and let them decide what information they can take away from the learning experience. And we should also try to involve learners in planning and in the evaluation of the intervention. Adults have diverse backgrounds, knowledge, skills, and previous experiences that they will relate to the new educational experience. Because of possible differences in the backgrounds and learning preferences of adults, it is important to offer educational materials and interventions with different levels of complexity and also different formats and styles. Adults are eager to learn things that will add value to their social roles. Therefore, the facilitator should explain to the participants how the educational intervention will contribute to their roles in the legal profession. Adults want to know how that information can be applied to solve problems immediately. Therefore, the educational intervention should include real examples and scenarios of problems that the judges and lawyers face routinely. And finally, as people mature, motivation to learn becomes internal. Therefore, the facilitator should provide valid reasons why the lawyers or judges should participate in each of the learning activities and assessments. Kirkpatrick, an American investigator, created a 4-level model to measure the effectiveness of training programs. The first level measures the satisfaction of the participants with the learning experience, and this can be obtained easily with anonymous questionnaires applied immediately after the educational intervention. The second level measures changes in the knowledge and the attitudes of the participants after the intervention. In this project, we can also use questionnaires to measure, for example, the knowledge and the attitudes of judges and lawyers about the benefits or risks of cesarean sections at baseline, that is immediately before they come to the event, and then measure again their knowledge and attitudes at the end of the intervention, immediately after the intervention is finished. And also a third questionnaire could be applied sometime later, for example, 2 or 3 months after the event, to assess the retention of their knowledge and changes in attitude. The third level measures to what degree participants apply or use what they learned in the training when they are back on their jobs. The fourth level measures how the educational intervention affects specific outcomes or results. For example, if there were any changes in the rates of unnecessary cesarean sections due to fear of litigation after the judges or lawyers were involved in the educational interventions. In this project, because of time and logistic constraints, we will measure the effects of the educational intervention only on Kirkpatrick levels 1 and 2. I hope the information that I presented is useful for your discussion about the educational intervention of this project during this meeting. And I thank you for your time.
So now we have until the break, over to you, about half an hour for discussion. After the break, we will come back and have one very short, hopefully fun presentation, and then we will ask you to move into 3 breakout groups, one looking at policy, recommendations for policy, one looking at recommendations for research, and one looking at potential educational tools that we might use going forward. So, and then we'll come back to have some more general discussion. So for now, any immediate thoughts, comments, queries, arguments you want to put on the table? I'll move back here. Yeah, I was going to say, I'm sure there's nothing, and there's not nothing.
My thought that came straight off my head was, I am Uma Isola. I work as the Director of Communications Alliances and Partnerships and Relationships at Access Health International. And the thought that came to me straight away was, when we are talking about women's rights, and we've had so many people and experts speaking about that, what is the level of education that that woman has to make a right, while she may not have the freedom in spite of the family? And what it came straight was, process happen. Because did we consider education, or did we consider only the family, circumstances as being part of the study? So,
Hello, I'm Dr. Suresh, Deputy Director at Public Health Foundation of India on Technology Innovations. Personally, I have 2 kids. Wife is around here, so no disagreements there. And both kids were born normally in her hometown, and that's a risky decision that I had to take. If I had listened to other colleagues, doctors, and perhaps like everybody else, 2 cesarean sections would have happened. And thankfully, things went on okay. Kids are good, marriage also survives. So again, another piece of evidence. The common theme here is that we are all part of a system. And unfortunately, the system presents distorted evidence. And again, that's all we seem to be having. As I said, if I'm going to get any help or any kind of support from the system, it's going to direct me towards a cesarean section. And that's because the system basically emphasizes services that are resource intensive versus something that is less resource intensive, because that's how systems survive. Okay? And that seems to be the common theme, not just to what you call cesarean versus normal. If I have to travel, I don't have a cheaper option these days. If I have to go to an airport, I don't have public transport. Meaningfully, I can't do that. I have to take a cab and then go, which is an expensive format. And that's what all evidence will lead to. And even if there is evidence which says that there is public transport, I mean, it will probably be the 100th kind of recommendation that actually comes up. So unfortunately, we are part of the system. When something goes wrong, the system automatically identifies who is the least powerful guy, singles him out, and then blames him. System never takes responsibility. That's the problem here. If there is a traffic accident, there is ample evidence to say that if you have a poorly designed road, accidents will happen. Roads are designed by governments, built by big contractors. Try going against them. There's no way you're going to succeed. The second possible reason would be the manufacturer, who skips on a lot of safety aspects which are proven to you can't go. So you quickly blame the driver. Almost all accident cases, you just blame the driver. In cases here, the doctor gets blamed. Although it could be several other reasons, including lack of a lot of equipment that is actually required to do all those things. The logistics chain, India has a poor record on even getting the drugs to wherever it is required. And all doctors work in a very compromised environment. But nobody would actually even recognize that or blame that. So broadly, the system, to save itself, would pick out the least guy and then blame him so that we quickly move on, because you can't blame the system. I mean, the whole thing comes crashing down. And circling back, I think all of these things would actually benefit from clear documentation, which unfortunately does not exist in India. Doctors could benefit, lawyers could benefit, and we live in a kind of a chaos that for a lot of people, they don't even understand how we survive and how we operate, but that's how we actually live. And this actually leads to a lot of subjective decision making, which if it works, it works. If it does not work, people get blamed. The least kind of powerful person. Usually it's the doctor. In most cases, even within a family, the person who has the least voice, usually the woman, basically gets blamed. That's what is seemingly happening. The way out of it is to create evidence. And this is a big question. Where exactly is this Indian evidence? You did a literature survey, nothing came up. We can't actually use Western evidence in Indian courts of law. So all the evidence that you said basically is supportive of normal delivery is not acceptable in the Indian courts of law. And if it's not acceptable here, I can't actually come out with frameworks. So where exactly is the Indian evidence? We have to generate. It's a process that has to happen, hopefully in the next 10 years, 20 years, pushed by insurance services and pushed by other players, we might actually get there. But till then, this confusion is going to exist, and we are going to survive in this confusion. The other last thing, with regard to this out-of-court settlements, if there is a property issue, I mean, I will go on for the next 10 years, 20 years, but here things, unfortunately, is of relatively no consequence because something bad has actually happened. So it's better to quickly settle and then go out of to the court and then quickly settle. There's no really point any going through this our court system and then waiting for another 10, 20 years. Nothing is going to happen. Thank you. Those are my comments.
Thank you. Anandita Majumdar from Indian Institute of Technology, Hyderabad. I wanted to ask Anna and take off from the lack of evidence conversation. And I think there is a lot of work in India which emerges from news reportage, especially in case of litigation work, because in India, especially in case of reproductive health and reproductive justice, litigation has, and there is vast amount of reproductive birth activism, and they produce intense reportage, which unfortunately is not documented in journals, but has the depth and the necessary kind of interventionist literature, which would help, kickstart this project even more. So I would actually, request you to look at that literature, because since the beginning of the Indian autonomous women's movement in the 70s and 80s, litigation has on reproductive legislation. And very quickly, I don't want to take out too much time, there is also, there's Kim Gusha, who's worked on India. There's Fauzia Taugi, who's worked on South Asia. There's Sri Parnayar, who's worked on obstetric violence. There is also, I'm forgetting, sorry, I'll come back to it. But these are people who have actually documented litigation. There is space for that kind of intervention as well. Thank you, this was fantastic.
Good morning. Thank you, Anandita. I'm Sriparna. I'm a social scientist, a medical anthropologist by training. So if my questions appear a little stupid for the doctors and the lawyers, please forgive me for asking these questions. The first question that I have, again going back to the evidence in the Indian context, is that we have a very high level of anemia in India. Most women enter pregnancy with anemia, so it's over 50%. It's even worse in some of the states in eastern, northeastern, central, and northern India, not so much in southern India. So in the context of very high rates of anemia, is it the case that the medically indicated nature of C-sections go up? This is a question. I don't know the answer, but I don't know whether the doctors here might be able to address that because of the risk of higher levels of postpartum hemorrhage if you have a normal birth. So that's my first question. The second status kind of thing, and that the women were well taken care of. I think there is some truth to it, because what our research has shown, where we looked at one village in Northeast India where the births have moved from the homes to the hospitals. that in fact going to hospitals and having this kind of highly interventionist care, Cecilia Van Hollen has also written about this, is a status passage. So that could be one of the social norms which are contributing to it. And the third thing in relation to operation that I want to say is that India has the highest rates of female sterilization globally. So that's the primary mode of contraception once women have given birth. So in this larger context, in the larger political economy where women's bodies have been the site where the state has done its reproductive governance, would it come as a surprise to consider? But thank you for the very rich presentation. I think there's a lot for us to take away from.
Thank you. My name is Dr. Ramna Rao. I'm working in the emergency medical services space, but basically I'm a public health person. I just wanted to remind the August participants here that in India, we were conscious about this fact for quite a long time, and as is reflected in the Protection of Women from Unnecessary Caesarean Section Delivery Bill in 2017. I'm sure many of you may be aware, but I thought I would just bring out certain phrases what are very critical here, and then it has got a very strong relevance to our discussions today. The preparation of capping of cost of caesarean section delivery is one thing which one of the paragraph alludes. The second is mandatory declaration by doctors and hospitals, which I wanted to really emphasize on that. Because I'm also having a 50-bedded multi-specialty hospital under my control, and we have a full-time obstetrician also. We are doing normal deliveries and cesarean sections also. So it is now mandated, at least in the state of Telangana, though not all the clinical establishments. I think in about 1 month time, it is mandatory that all of us have to really declare on individual births also, whether it is normal birth, or I'm sure there are practicing clinicians will be able to allude more on that. The third point is the constitution of Caesarean Section Delivery Control Board is very, very important, I think. And finally, the functions of the boards were also mentioned. So my simple statement is there are certain important policy decisions taken, but we may be failing in effective implementation is one thing. Second, like I agree with some of the statements which are made that we here as a doctor, right, masterly inactivity and watchful expectancy is what we have learned in medical schools. But once caesarean section is always caesarean section is another thing. And third is that it has become a social norm, right? But I also want to make one more statement at the end, because when we deal with emergency obstetrics, I'm not talking about elective caesarean section, but I'm talking about emergency caesarean section. We have come out with a lot of evidences by using a model called a common mental model, right? So whoever is the team involved with the caesarean section, they have to take into consideration. So I'm talking about decision on the higher number of caesarean sections. I'm sure that these are some points which I'm able to communicate, and thank you so much.
Hi, I'm Gauri Iyer, faculty at IIPH Hyderabad. So I have two questions actually. One, in the scoping review that was done, the legal scoping review, looked at the percentage of medical legal cases in India. How does it compare to globally? Is it low? Yes. So then how is fear of litigation, is that a driver at all in any of these decisions? Second question that I had is, I know you hinted at it when you were talking about is how do you disincentivize a system to take less invasive procedures when you are incentivized constantly to go on for more procedures, which helps the doctor, helps the insurance companies, helps the system. Then how do the doctors ethically perform their, when they're incentivized constantly to do the opposite? And I I think the third one is, I think, more about the possibility to improve. I think the stakeholders, the health literacy, the responsibility of different stakeholders in improving the health literacy. And I think you've touched upon women's rights and the whole how women's consent is an issue. All that will come later. But these are mainly the two main systemic broader questions which I think probably hinder significantly in any kind of maybe significant ways to improve this.
Yeah, good morning everyone. I am Dr. Narmada, gynecologist. I am in this field since 36 years. I did my undergraduation, post-graduation and teaching and professor and everything. I retired from Osmania Medical College and I worked in Gandhi Hospital. And really in India we say labor is one punarjanma. Punarjanma means rebirth to the woman. Okay, the energy of labor is different. Waiting for the baby whole 9 months and all these functions they do in between 5th month, 9th month, like baby showers and all. For obstetricians also, before delivery they follow the patient, and during delivery, after delivery also they follow everything. If anything goes wrong in this scenario, and total thing will get impacted, things. Especially and all kinds of media, papers, televisions, politicians, mostly I can say politicians, they are involved all these things. That is the reason, and just I am representing all obstetricians. That is the reason if anything happens, obstetricians may feel bad about her career, and also psychologically they get upset, even though they are very much senior and as well as competent. It will take 2 to 3 days to deliver a baby, 2 to 3 days. In multigravidas, of course, it is, they can finish so soon. And also, coming to the cesarean section, we can do within 15 minutes, A to Z. It will be finished. So one more thing I would like to enlighten, all deliveries will come in the midnight. All deliveries occur only in the midnights and the early mornings and odd timings, Sundays, second Saturdays, festivals, these are the things. So these are the few important things I would like to just tell you. And this is also one more thing, and if anything happens to the obstetrician or to their hospital, no one will come for the support. And entire society will be against it. Except in the hospital premises itself, only 3-4 people will be there. And in this case, and in solo, suppose one small hospital is there, there's some 30 bedded, 20 bedded. Only 1 or 2 gynecologists will be there. 24 hours they have to monitor with vigilance, then only it can happen. So this thing is, one more thing I would like to include in that, and after having normal delivery and all sexual character, we have normal delivery, that my partner may not be satisfied, and if we have cesarean section, is there any difference? There, that question is also there. Sorry, yes, yeah. Yeah, it is done.
Thank you. Thank you, very helpful.
Coming to, in India, rural and urban difference is more. In urban areas, and cesarean sections are, of course, they are 3 times more than rural areas.
Thank you very much.
Thank you.
Yeah, thank you. Very good to have that perspective. Yeah. Could we hear from a lawyer? Are there any lawyers in the room that want to, I think we've got some lawyers in the room, that want to say something? Yeah, thank you. We've got another 5 or 10 minutes before we break for, there you are. Before we break for our break, so it'd be good to hear from a range of people. Who's this one?
Hello everyone, I am Dr. Pallavi from Fernandez Hospital. I am a consultant obstetrician and head of the obstetric services at Fernandez. So our setup is a slightly different setup from what Dr. Narmada had shared. So it is a place with a combination of midwives and doctors. So our practices are like proper practice that everybody wants to have. So that is cesarean section because the risk of PPH is anyways there. Be it a normal or be it a cesarean section, the risk of PPH is anyways there. So I don't think anemia as such would be a reason to have cesarean sections in most of the settings. The second one, section and sterilization is something that you wanted to ask. Yes, that could be one of the things because most of the times like a sterilization and completion of a family kind of a thing. Yes, that is a little part of it. But here, the main thing is educating the women and educating the families. All the problems that Dr. Narmada had shared exist. And we are from an ideal setting where we are privileged to work with combination of doctors and midwife and lot of support system, which is not true in more than 90% of the situations. So for me, when I joined Fernandez, it was a new thing for me, where I would think that these are different practices, and there were midwives who were don't come into this. We would take care of this mother. You don't have to interfere, and people whom we would think that they would have a section definitely would have a vaginal birth because I don't know what they would do inside. So with a lot of support and then talking to them, talking to the families, that makes a lot of difference. So here the role of introducing lot of midwifery colleagues and labor ward nurses would change a lot of practices where doctors would concentrate on the high-risk women and leave the low-risk mothers aside. Here the sections are more in the low-risk women because the waiting time, talking to the families, we don't have time to talk to the families. If you leave that group of women, which is more than 70%, then you can definitely help those women have vaginal birth. So introducing midwifery services in most of the hospitals, getting labor ward nurses or support nurses if you don't have midwifery system, because they would take care of them. Then the doctors can concentrate on other things or high-risk women. So I think here change of our mindset and change of practices is something which is very, very, very essential and need of the hour.
Thank you very much. Yeah, great. So, lawyery person? We've not got any lawyers around us.
I have the mic.
As repeatedly commented by the WHO and all other organizations, we play a little role. Whenever a doctor client or a victim comes to us, then here we have to develop a sort of awareness among lawyers and judges. That is important. Regarding the practice and operation of law, whether there is negligence on the part of the doctor, whether the C-section is necessary or unnecessary, these are all merits of the case. So first of all, there must be some awareness in the legal fraternity regarding the caesarean operation and non-indicative and all that, because legal fraternity doesn't know all these aspects. You can observe the poor presence of lawyers and judges for all these workshops. They are not able to come. They are not able to visualize the importance. That's my submission. So first of all, let us sensitize the legal fraternity, because there are so many doctors, but one or two lawyers. So that's practically I'm submitting. So this is my submission.
Thank you. And maybe in the workshop later, you could suggest how we might attract more lawyers to come. So we have more.
To assume an expert medical person to consult with them on the case would actually, rather than relying on their indigent knowledge or whatever their expertise, to get the expert witness or to expert consultant to help to be per case. So as and when the case comes to your desk, you have to make sure that you kind of have a panel of you able to approach a medical expert to help you consult with the case, to prepare the evidence, to help you kind of that might be more helpful.
Yeah, I think they do have medical experts. The question is the credibility of those experts is one of the questions.
So,
hello. వస్తుందా?
Because we are talking about the medical experts and all, then we have the associations, obstetric association. Probably you can, take the help of the association, and from there you can take the experts.
One more question or comment, and then we'll break, and then you can have some more conversation after that.
Hello, I'm Dr. Sugna. I'm working as consultant gynecologist for Piramal. I have seen a patient, we told her it would be a normal delivery, but in the process of the second stage, there was fetal variability, fetal distress, so we had to do section.
with the consent. But after that, they became very aggressive that it should have been, even her husband was saying the same thing. We had to convince them and teach them about what is fetal distress and in what circumstances we had to do that. So what in India we lack counseling and educating the pregnant women about the physiology, what happens, in what circumstances we could go to section suddenly after planning for normal delivery. So what I would suggest is most of the going to the lawyers, patients are all educated. So what I would say is that they need, during this 9 months of pregnancy, they need counseling sessions by the obstetrician who is treating to tell pros and cons and how they could go in emergency to a section instead of normal delivery. That is at least during that 9 months, at least 5 or 6 sessions the pregnant woman should have. So she will have the clear concept of what is the physiology of pregnancy and where what could go wrong. So I think all of us should go for these sessions for the pregnant women to reduce the misconception about pregnancy. Thank you very much.
Thank
it was
you
a
very
very
much.
wonderful session. We could learn so many things and share so many things about it.
Brilliant.
Thank you.
Oh, okay. Well, we're going to take one more question because it's from a lawyer. And then we're going to go for a break.
So, a little repeat of yesterday, but as I said earlier, that we have to see law helps everyone from that perspective. And the other fact that now the numbers or the percentage of cesarean is so high, everyone understands that it's unnecessary. And so the self-regulating ethical framework is actually not working. So what was unethical or still unethical, which everyone agrees it's unethically happening, unnecessary and unethically happening, now how that also becomes illegal or unlawful. So that framework has to come in place, and that should not come through lawyers, it should come through practitioners. Now what will that framework be? One, what that different stages of data sharing has to happen so that tomorrow it also saves the doctor. So how that dashboard or whatever it has to happen where every stage of the procedure gets documented so that tomorrow it helps the doctor as evidence support. And it also should also lead to more transparent, which I think many of us are sharing, that it should be more transparent communication between the two so that it becomes a more informed decision making. And it will obviously lead to lesser violence and litigation with the fear which we are talking of. So I think that framework in form of a guideline or a law, whatever, has to happen because we have moved much beyond this ethics framework. And we are now in a serious situation. Thank you.
Thank you. We'll break now for a break. I just want to put one small thing in, just take chair's prerogative. Maybe it should be an alliance between lawyers, women, and doctors. That would be great. So thank you.
We have a small announcement. We have a small announcement to make. We have all of you as guests. It's great to host all of you. And we also have Professor Sue and Dr. Anna coming all the way from England and Switzerland, WHO Switzerland. So may I now request Professor Geeta, Dean of School of Medical Sciences, to kindly felicitate Sue and Anna. Dr. Anna Pillar as well. We'll break for lunch and, break for tea. Tea served just outside this door.
Somebody is really hungry.
Is everybody back? Let me just check outside. Yep. So, can we come to order and then we can plan the next session? Thank you. It's good to hear the conversation. Conversation's what we're here for, but there's also a time limit, unfortunately. So, can we stop all peripheral conversations? Thank you. Okay, so for this next session, we're playing it a little bit by ear because we haven't done it before. So what we want to do, as I explained earlier on, is have you in 3 different groups to discuss possible solutions. So we've raised some of the problems this morning, and now we're looking for solutions. So in your groups, if somebody says, well, you can't do this because, then challenge them and say, let's find a way of doing it, even though there's a problem. So the task for you in the group is to keep all of yourselves aware of the issues, but also focused on the ways we're going to solve those issues in the long run, whether that's at an individual level or an organization level or a society level, whatever. And they also need to be solutions that you can do something with. So yes, the system is a problem, but change the system is not a solution. To change the system, you have to deal with people because people are the system. The systems don't exist without human beings. So if we want to change a system, we have to work out ways of operationalizing that change. And we would suggest, again, you don't have to, but thinking about what makes things easy for people, normal in their area, and beneficial is going to be part of a solution. And that includes chief executives of organizations. So how can you make it easy, normal, and beneficial for the chief executive of a hospital, a private hospital, to incentivize their obstetricians to optimize physiological labor and birth, while also making sure that cesareans are done when they're necessary? How can that individual be enabled to make that happen? Or how can the obstetrician on the ground be enabled to get beyond all the fears and emotions and stresses that we heard from so eloquently, to be able to offer a range of positive choices? Or how can we help the women who are working with or talking to their families stand up and say, actually, having looked at the evidence, I think, and you know, in consultation with my obstetrician, I think that I should aim for a normal birth, although I know that if I need a cesarean section, I trust the doctor that when they say I need a cesarean section, I do need a cesarean section, and that will be fine. You know, so your task is really to come up with something concrete that we can do going forward with this project and other projects in future. So we have 2 ways of doing this. We can either just number you 1, 2, 3, 1, 2, 3, 1, 2, 3, and then we'll say all the ones go in one group, 2s and 3s, or we can put you in the groups that you want to be in. So I'm going to do a show of hands first. If your choice is research, recommendations for future research from now onwards, recommendations for policymakers, or recommendations for educational tools and approaches, I want you to put your hands up when I call each one out. And if there's an even balance, that's fine. You can go into those groups. If it's very unbalanced, we'll have to go with the 1, 2, 3, 1, 2, 3 thing. So first of all, who would prefer to be in a group talking about future research? Well, that's a very small group, but okay. Start to pretend. Yeah, we've got some. Who would want to be in the group talking about policy recommendations? Somewhat larger group. And who would want to be in the group talking about educational tools? Okay, we're probably okay. Yeah. We're probably okay. We're probably okay. So, well, I know we did originally want to give you the option to go to all 3, one after the other, but then you ended up with. You could float. You could float. Is that what you're thinking? Floating. Yeah. Yeah. Right. So I'm going to tell you that. So what we want you to do is you're going to go in your 3 groups. We're going to give you some post-it notes, and your first task, without discussion, is to write down on your post-it notes 3 things that you think are relevant to your group that need to happen. 1 for each post-it note. So if you're in the policy group, 3 policy ideas on separate notes. If you're in the education group, 3 education, and if you're in the research, 3 research, without conversation or discussion. And then we want you to go and post them, stick them on a wall somewhere, nearer to wherever you are. And as each of you puts your post-it notes on, you should be able to see if other people in your group have said similar things. And then you're allowed to have a conversation. So then we have about 20 minutes where you can discuss what you've come up with. And then we want you to finish off with between 4 and 6 recommendations for your particular group that we're going to bring back to this general group to share. And at that point, we are going to use Mentimeter. I don't know if anybody's used Mentimeter, but it's quite a good way of very rapidly getting responses from the whole group. So with Mentimeter, we'll put the recommendations up, and then we'll ask you to vote. And then we'll end up with the top 4 or 3 or whichever. And we've already allocated a student to do that work for you. But then what you also have to do in the group is decide on a rapporteur. So one person can come back and then have 5 minutes to describe what you've come up with and why, with one slide. So the students will make the slide, but one of you needs to come and feedback. Is that okay? So post-it notes, conversation, your top recommendations, and appoint a rapporteur. So we'll just float around to make sure everything's okay. So we have 3 spaces. We have here, we have outside on the terrace, and we have next door there. Or you could just be at one end of this room and at the other end of this room. So maybe the smallest group, which is a research group, can decide if they want to go outside or in the lobby out there. So those who are in the research group, who had their hands up for research, where would you prefer to go? Out there or out there? Outside? Okay. Okay, I'm going to... Sorry? You want to stay here? Okay. So find yourself a corner right the way over there. Okay, and you have... yep. Okay. So I think the largest group, which was the policy group, needs to stay here because you're large. So you need to assemble over that way of the room, if you can. And the education group, you can decide if you want to go out there or in the... Have you decided? Where do you want to go? Okay. So the education group, I'm going to make a decision for you. The education group goes out there, okay? Education group out there. Policy group, this corner. Research group, that corner. For policymakers. Yes, that's what you want to do. Definitely targeted. They must be achievable. Achievable, yeah. So research. Oh, is this the research group? No, because you won't be able to hear, because the policymakers are going to be here. So you have to be separated from the policymakers, basically. So I think the research is going to go, we'll bring the flip chart over, research over there. Otherwise, you'll just hear each other's conversations, it'll just get really confusing. So policy over here, good, good, you're sorted. Education out there. Policy's over there, yeah. Sorry? So typical researchers, resistant. Like, I've got alternative hypothesis here. I want to sit here. Bring the flip chart over. Right, where are the posters?
is important to monitor whatever graphical representation of progression of labor. GOI has advocated to use simplified photograph to monitor progress of labor. This is a medical legal document and should be part of every case sheet. So for that, auditing office is regulation at each facility, government and private, is directed to do audit of all the civil sections done on monthly basis, along with indication, so that data analysis can help to reduce the rate of unsolicited infection. A complied monthly report minutes meeting should be sent to Falana email. On the 5th, which we heard, I am not sure if it is right, the gap is in the package.
ఇంత కవర్ ఇంత బాగుంది
What is that framework has to be done by the state. I mean, I'm talking about the names. We are not like that, we have already.
I would like to mention, you have like to accept this stratify. One is the general awareness, and that includes, or I think every group some level of awareness. The second is the more formal sort of education tools, which one would be for the legal profession, and the other would be those who are involved in the actual delivery and clinical care process. Then you have supportive staff and those who actually do the delivery.
all the work you've been doing in your groups. It's been very impressive, what I've heard anyway. And now we're going to have the feedback. So we'll take it in order earlier on with the presentations. So if you just listen to each feedback, we're going to make sure it's no more than 5 minutes. And then we're going to do an exercise which hopefully will stimulate conversation for the remaining group I put together, 4 to 6. So if you could just listen for 5 minutes each now without saying anything, and then we'll give you a chance to talk again. As I said before, we're going to start. Rapporteur for policy? Anybody rapporteur for policy? Oh, yes, that's true. Education is right on it. Okay, who is the rapporteur for education? So we've been slandering policy, and actually education isn't ready. I mean, have you chosen your rapporteur, policy people? So, do we have the slides for policy? The first one, yeah. Oh, no, he's... Well, let's do it in the order we've got it, actually. Now you're here. So we will start, now we have a rapporteur for policy. We'll start with policy, then education, then research. So you do have a few minutes, yeah? Okay, sorry about that, calling you away. Yeah. Depends. Slides come up.
Okay, good afternoon, everyone. I'm Dr. Jamuna Devi from, senior consultant, and I was partner. I don't know how far we are, and so to reduce the cesarean section rates, I think the first and the foremost what we all aspect, I think it is easy to do as a policy makers. And I think to revive it back again and make it more, professional. And that is the first recommendation we are doing. And we are recommending IEC material, that education, communication, information material to the women and the families. So we can disseminate these materials when she is pregnant, like we were doing for family planning. The government was doing for the family planning. You are two, you have two more to bring down the families into a smaller group. So same way we can recommend that they develop these materials so that we can educate the woman and the family. Then the third one is mandatory implementation of Dakshata or Manyata. These are the modules, training modules, which are developed by FOXI and Government of India. Both are same, and these should be implemented to all the private hospitals, so that there is a uniformity in giving standard of care. There is no lack of care given. Then we have recommended transparent dashboard. Then third one is feasible fee structure implementation. I am doubtful whether the private players would agree or not, but this can be recommended. And the committees should be formed with a medical professional so that they can regulate the cesarean section rates in various districts and or states. So these are the recommendations we have. Thank you.
Thank you, sir. Hi, I'm Nanda Kishore. I work for Indian Institute of Public Health, Hyderabad. And Dr. Suguna, Dr. Anita, Sudha. So we deliberated on the need for education at multiple levels and the need for community engagement. The first aspect we spoke about was how do you really reach out to the larger community, and at the second level, how do you reach out to the semi-skilled across the legal and health systems and the skilled. So that's the three stratifications we thought we should be working towards if you really want a efficient community engagement on the problem of rising C-sections. So as a part of the tools and curricula, we thought for the general public, we have very established tools in public health like the community street theater, community dandora, and also we need to look up to the emerging mediums such as social media and digital tools to reach out to the larger general public. But the focus should be on the issues such as the socio-cultural norms, which are shaping the issue of the larger, increase in the cesarean sections. But that apart, also as some of the discussions in the morning, the prenatal, antenatal, and postnatal context of the birthing process, and from the rights perspective, what are the rights of the users, the mothers, the families, and the service providers, the legal and the regulatory frameworks, and the emphasis on the consent, ethical and consensual process. All this should be a part of the content through which we could establish the community engagement on this problem at a larger level. The second recommendation was about the specific curriculum, creating the culture-specific or the stakeholder-specific curricula with an emphasis again on providing short-term training programs, which could be a hybrid model, which input skill enhancement programs. For example, we considered the legal providers, and the curriculum could be, focusing on reaching out to these participants, and mock codes, all these things could reach out. We could reach out to both the legal and the health systems, the stakeholders from across these groups, so that the emphasis for the legal providers could be more about public health law, but for the service providers, we could talk about how the permissible, restricted, and non-permissible ways, an algorithm should be, the knowledge about this algorithm should be propagated among the service providers. And similarly, from the rights and regulatory framework. This was in a nutshell.
Team and educationist, one medical doctor / epidemiologist, and yeah. So broadly, we were able to, and some students, 5 themes we broadly kind of divided them into. The first one, I think, which was a common theme, was generally about, so even though it seems like a topic for a research, it could be used to design an intervention, so education of stakeholders. And I think there were several ideas on trying to, educate the different people involved, whether it is the doctors or the women. Things like the medical curriculum, changing how, yeah, so I think this also, again, one of the interventions actually was trying to look at an experimental in the control arm about having one dedicated MSW or a person who can work with a team or, with the pregnant mother and the family during the course of pregnancy to see if there is any change in the outcomes for those particular arm of people who received that medical social worker. Working on, yeah, I think that's, so, I think one of you, yeah. So education revolves around mostly, yeah, reproductive rights, about education, about the information regarding that. Then there was, right, okay. So that was the point made by Dr. Sunita, and she was actually talking about including rights-based a module on rights. Same argument, you can also talk about the fact that the medical, I think one of the points you talked about was about the medical curriculum also, which I do resonate with. Medical curriculum, how much does it focus on ethics? How much does it focus on these kind of scenario-based learning? And one of the things I learned when actually incidentally when my daughter was going through preparation through the UK system and the Indian system writing the exam, I was very impressed by the fact that part of the test-taking process to learn for the exam for the medical board or to apply for the UCAT or BMAT, whatever, is they were given there was this module which was emphasized on scenario-based ethical learning, which is missing, I think, in the medical curriculum in India. I know there was a recent revision in the medical curriculum that happened in the last few years, where there is supposed to be an increased emphasis on ethics, but I'm not sure if there's been a very deep dive into how impactful that has been. Yeah. Then, so that was about the education, and interventions around education is about, could be anything. You introduce various interventions to see which could work, whether you inform the family, you inform the doctors, you sensitize the doctors, and how do these different interventions impact outcomes. Then the tech and info and data, I think here the point raised by Dr. Suresh was that generally improved documentation and improved electronic health records, how do they change the outcomes in these situations? We don't have that kind of data, and having that kind of efforts to improve documentation, does it make a difference? Then I think there were a few comments, suggestions about generally having a comprehensive situational mapping of the issue across the country, regarding this issue, and I think broadening it across other countries in Southeast Asia generally as a comparative analysis, and looking at other countries where incentives, the different kinds of incentives have worked and how have they worked. I think this is all to do with comparative analysis and situational mapping. Okay. And the last is institutional, and so from the institutional perspective or the hospital several factors which could be about the service delivery, what are the factors which could work, looking into that, yeah, mapping, and yeah, going in, I think mock courts, like the person talked about here, actually encouraging the doctors to go, or even the researchers actually, to go into the courtroom to see how judgments are decided, not just looking at the outcome or the judgment, the finality of the judgment, but the process of how the judgments are actually made. And I think I've covered all the, yeah.
So that's the first thing to do. What have you got with that? Have you got Can we show that on the screen? We'll show you on the screen what we think you should be seeing. Hopefully you'll be seeing it. Yeah, policymaker recommendations, was it? Right. So when this pops up on the screen, we'll tell you what to do. Okay, great. So you should be able to see some questions. I don't know why you can't see the questions here. We'll go into screen share, is it? Yeah. You've got the number at the top there. Just for those who might have missed the number. Okay, so we'll just check you've all got the number. I don't know why I've just seen the picture. We might need to give you. Oh, you've got it there. Okay.
Or you have to. So everybody is inside. Okay. So then, what we are going to do now is we would like you to vote for each of the research. You've done it already.
Yeah. So put your votes in, and they'll show on the screen.
Fantastic. This first one is for policymakers. I need to vote.
Oh, okay. Has everyone managed to vote? No, people are still voting. We can see them. Obviously, to Gates, but also where we can, and we're hoping there's some policymakers in this room to take it forward to policymakers to make discussing, because we want to share it with everybody, if that's okay. There is a plan. Yeah. Yeah, we can see. Has everybody finished voting, or are you still doing? What we're going to do is we're going to discuss this one and the issues around the policymakers before we move on to the next one. So we'll just see what we're going to bring it forward so you can see what's on the screen here. Is that any clearer? So what is top of the list so far is midwifery programs to be implemented in the private as well as... Sorry? I'm sorry if people can't get the temperature in this room. So number 1 is midwifery programs. Number 2 is IEC materials. This is actually more or less in the order they were presented, which is interesting. So there's some presentation bias here potentially. Transport dashboard is 3. Oh! Mandatory implementation of Daksha, is that? Yep. Training module is equal with a feasible fee structure. So I think what it might be useful to do is to have some conversation about this order and these choices. So does anybody have any views or thoughts about if we were to take this to policymakers in India, who would we take the ideas about the midwifery program to, and how would it be most possible to influence them? Does anybody have any ideas about the optimum way of influencing people? I wouldn't worry too much about it. So thoughts about the midwifery program to policymakers and how we might do it?
I think I make it a point to go first so that the conversations start getting stimulated. I said, I think I make it a point to go first so that the conversations start getting stimulated. Health is a state subject in this country. And while we have a Ministry of Health right at the center, health and women's welfare is very much a part of it. But if you look at each of the states have commissions that are there, and they also have the state regulatory authority. And especially in Telangana, C-sections is one of the major areas that they continue to work on. So I think they would be very interested. The Commissioner of Health and Welfare and the the Principal Secretary of Health are the two people that will be the people whom you should approach, or people that need to take these recommendations to.
Response. Because obviously you just rock up to the policymaker's office and say, we need to have midwifery. They're going to go, and who's paying for that? Presumably. And who's going to educate them, and where they're going to come from, and all those things?
If we have data on the long-term outcome, so short-term gain, but long-term problems. So if we have that data ready, because someone mentioned it in the presentation, that would be one of the points to argue on. Yes.
Yeah, okay. Any other levers that people think the policymakers might have at sector? Because that's obviously a more difficult nut to crack for the government. What else could policymakers be persuaded with?
I'm Dr. Jalaja Veronica from government sector. I'm HOD at MCH, Maternal and Child Health Center, Hyderabad, who reviews our data, like what is the percentage of normal deliveries, for the fear of him, like we have, most of us have reduced our section rates. So he will just question us why your section, in your hospital, why the section rate is so high. So in our hospital as such, in collaboration with Fernandez, we have midwives who are being trained. Third batch is getting trained. So they are of good help. We just rely and they counsel them during antenatal period. And then during the interpartum, they give birthing exercises. And we have Entonox with us. So the patient has that confidence that if I have more pain, that most of our patients, they don't want to wait. The clients, they don't want to wait for longer hours to deliver for that period of that thing. So when we offer them different things, they are ready to wait. The counseling part, the birthing exercises, all. So there are patients who have waited for 2 days also for normal delivery. As the trend is changing slowly, it takes longer. And this is in the notice of our health minister and the higher authorities. So maybe we can recommend them that this program is only the third batch is going on. It's still new. So maybe at a larger scale, if we go and recommend them about this midwifery program, which will be helpful everywhere, because even the private practitioners, they can employ midwives. So that
examples of good practice, maybe, places where it's worked could be quite useful for policymakers. Okay, we won't have time to go through all of the items, so we're going to basically do the top one and see what time we have left after. So there is hopefully there's another slide here, if we can go down. Can you see it on your phone? There should be a slide after this one, which asks you to put your reasons for your ranking here. Can you see that on your system that you've got? Is that not on there? We might have to just stop with these ones. So can you want to, yeah, that's it, that should be it. So we can see at this end. Let's see if we can post it up for you somehow. Yeah, we should be able to, so can you get down to the next one after that? Just talk amongst yourselves for a minute while we sort this out. Not that, no, that was the other one. 6 slides. Should we see all of those? Technology, eh? We love it when it works, don't we? But, it's always a bit frustrating when it doesn't. It doesn't matter. If we can't make it work, we'll go back to a general conversation. But what you can do with this second slide is you put your views in and it makes a word cloud in real time, which is quite fun. But, and we thought we'd end up the day for you with something a bit more fun. Yeah, that's the one. So they should be able to see, it should be possible to see then. So just press done. Yeah. We're hoping we posted it for you. We did test this out, Try putting the code, if you can go back to the beginning and try putting the same code in, 71270334, and just see if it gives you an alternative option. Okay. So we may actually have a problem with it updating because of the Okay, try this code as a new one. So 1449 1698. So 1449, not this one up here, 1449 1698. Is that the actually the set of questions? This is a frivolous one, but I want you great. This is just so we can see how the word cloud works. Great, you got it? So if you can answer the questions on that one, and hopefully you'll then get a second slide, which will ask you why you made the decisions you made. And no, the first one is about cake, yes? So do you have the option for the word cloud on this particular one, or you just got the first one that you had before with the cake and chocolate? They might not have it anyway. So let's just look at the cake and chocolate results if we can't do it any other way. When this works, it's great fun. So one of the things we wanted to just suggest to you that this could be a way of working with some of the students for some of the educational programs. But obviously, we'd have to make sure it's watertight before we did that. So we haven't been able to do that on this particular occasion. So we'll try and see if we can see the results of that one, just so you can see that it does come up the same way as before. Always use factor 30 sunscreen is number 2. Chocolate should be available on prescription. Quite a lot of you still thought that. And the one that was people had least confidence in is that everyone should eat cake once a day, which seems very sad, really. I think cake once a day is surely important. So I'm sorry that you didn't get to do the whole piece of that. So what we now need to do, I think, is discuss the other two groups that we didn't have a chance to discuss, so the education group and the research group, and get some conversation going about how we might enact what they said. So maybe if we can go in the order before. So the education group, do you want to ask questions of this audience about how your educational responses might best be put into practice? So who was the rapporteur? Where's the rapporteur? Oh, he went. So anybody from the education group? Oh, there he is. Okay. Yeah. So you have the floor. You have the floor to ask the audience about your recommendations for education. So anything you think that we can
Okay.
further elicit.
So, sorry, can anybody remind me what recommendations were? Just kidding. No, I think the recommendations were to be more in terms of designing these stakeholder-specific training programs, and content should be more about, general population, which includes, I think I would refer to my notes, yeah. So it should, yeah.
It was more to ask them to talk.
Yeah.
So not too much time on this. But
No, I won't take much time. I'm hungry, so yeah. Yeah. So first is culture specific or the tools for generating general awareness among the population. Number 2, having very specific interventions for both skilled and semi-skilled. The semi-skilled includes health system and the legal as well. To be co-designing the curriculum, having short-term education programs. And number 3 would be more about having training programs for service providers as well, but largely designing the curriculum more towards each of the stakeholders. Yeah, and the regulatory frameworks and also algorithms, specific algorithms for in the context of the cesarean sections. So I think that's. I think. Sorry. Yeah. So would any of you rate them in an order of priority between these three? One is specific general awareness for community engagement. Number two, short-term skill building programs for one, legal and paralegal teams, and number three, healthcare providers also. So among these three, which intervention do you rate the first? Ma'am? Medical professionals, okay, number one. Allandar general dantlo ostar madam. General public law, it's all the stakeholders within the community. Sorry? Yeah. So general group, as you said, all the political representatives. Sorry madam, చెప్పండి. అవునండి, they are part of the general group. This. Yeah, that is the legal kanna, this political influence is higher, I think. Yeah. Yeah, I think, hands up for the first intervention, general awareness. Okay, general community engagement, which includes all the politicians, local representatives, women, families, I think. Yeah, anybody is counting? Karthik, count yes, sir. So general community engagement, general is number one.
No, I'll use the how it's listed.
No, that's not listed there, so I want it to be the way I am saying.
Okay, one second.
Yeah. Sorry, what was the general first intervention is community engagement, general population. 5, 6, 7, 8, 9, yeah. Number two, skill building and short-term programs for the legal fraternity. Hands raised, please.
Skill building and?
1, 2, 3. For the legal fraternity, short-term. Yeah, 11. Number 3 is again further medical fraternity. The health services providers, algorithms, yeah. Yes. 14. So, Sunny, 14, 11, and the third one intervention. Yeah. Thank you.
Great. Well, I suppose they can now ask why though. So why is that?
Okay. Your reasons, please. Why do you think community engagement is least rated when compared to the others? What is platform? Yes, sir.
General philosophy is that you must have your house in order before you start talking about what is available.
Yeah.
Now, if you put the community first, even without your infrastructure, your attitudes being addressed, you can't go to the other. That is the reason why we need to start there first.
So start with medical and first thing, because we need to set things in order first to be an exemplar to the community. I think that's a good point. Sunny, did you make a note of it? The reason, should I write it down?
So these,
Okay.
so the other reason,
That's
Nandu,
one reason, yeah.
the other reason I would think is that the medical fraternity is very small in number and deals with a large, big community. And the lines are very blurred. So from what is permissible to what is non-permissible, there is a huge journey, but the lines are very blurred. So if they are well equipped to take on those lines and make those grays less gray, then it becomes easier for them to reach out to the other stakeholders and other groups. So more than anything else, they're a smaller community that takes care of a much larger community and have to deal with many lines which are not exactly clear.
But do you think that's easier to intervene, or the blurring lines would be difficult to deal
See, whether it's difficult or not, it still needs to be taken on in priority.
Okay.
It is, whatever you do, it's never going to be easy. Whatever interventions you plan, Since any change is not easy to bring about, it is a difficult.
Good. Thank you, Uma. Anybody else? Sir.
Hi, I'm Sudha from Pineapple. One reason I feel is I don't decide as a woman that I will have a C-section. It's the doctor who decides. So the journey starts there, so maybe those are the target group first. That's my reason.
So you mean community should be the...
No, the doctor, the medical fraternity.
Okay, because they are the ones
who decide I will go for a cesarean.
And the women do not
it's
have
not
the agency to decide.
Right.
It's the doctors. Okay.
Right, thanks.
I think that's also a good point. Anybody else, please, for reasons for your ranking? Anybody from the community engagement bit? Anthropologists in the group? I'm trying to drum up some support. Yes. Thank you.
That's fantastic. Now, we think we've sorted the Mentimeter out for the research group. Do you want us to try it again? Or do you want, you do, okay. So we apologise if it doesn't work again, but we'll give it one more go. And then otherwise the research group, you'll need to manage the debate as we've just managed with the education group. Also policy group, I'm aware that you didn't have much time for conversation. So if we have time left, we'll also come back to you as well. Right, it's all on you, Sunny. This is your code, put it in, and we'll hopefully get both the questions up for you. give you another 2 seconds. Oh, there's a few more coming in. No, that's fine. I mean, we're only testing it anyway, so it's just it's not a scientific exercise. It's really just to get a sense of the feeling in the room, which is fine. And obviously, in this, we're not forcing decision with this particular mode. So if you use this software, there's certain modes where you force a decision. So you have to choose one thing, but we're not making people do that with this one. Yeah. Okay, so it looks like education of stakeholders. So this is where the education group gets 2 bites of a cherry, because the education of stakeholders has come out on top. So it does seem from the previous conversation that that is a really big issue for both research and for education. Institutional research from a medical legal perspective comes out next. And then 3 people have voted for the non-question, which is interesting, but never mind. Well, there's 3 votes. Oh, you still put it? Okay. And then we've got interventions around education, then we've got information tech, and then we've got situational mapping. Now, I wonder if we can move to the next question, can we? Yeah. So hopefully you can see the next question on your screens. If you might have to click something to do it, I'm not sure what, but see if there's any signs of anything. Yep. You should hopefully see it on the phone, and then you type the numbers in, but the words in, but you're not getting the second slide? No. We must have actually, unfortunately, there must be a glitch in what we're telling you. I mean, it's something we don't understand, that we need to tell you to move to the next slide. And I think it might take us too long to work that out. Sorry? Sorry? Same questions again, is it? It should be a question that says, please give the reasons for your choices, but yeah, then if they're not seeing it on their phone, then we can't do anything about it. Okay, so can the research lead person or whoever come up and, again, like we did with the education group, just check? Oh, okay. Let's just try this. One more thing. Try this code with. Yeah, okay. I'm going to stop this now, because otherwise we're going to fiddle around with the text so long, we're not going to have a chance to have the conversation. So let's stop with the minutes. So I don't know if somebody from the research group wants to manage that this conversation like we just did with the educational group. So just any thoughts or comments or advice or funders even. I mean, one of the questions here is, where would we go for the funding for the things that have been prioritized?
So suggestions is what you're looking for? So what are we actually, what is this exercise?
So what we want to do is we want to, we've got the priority already. We want to find out where we might get the money from, or why that is the priority, and how we might progress that research question.
So information, this is education of stakeholders.
That was the first one.
So suggestions of where you would look for funders. So I think the question is about, we had these, all of us had prioritized these themes as to what are important or more important. And I think her question is, how do we go about designing or looking at projects or looking for funders to support these projects? Who do we go to? I think government may be a good option, one going to the government.
So anyone who is in the social sciences right now and works on any rights-based research in this country knows what the funding landscape is for us, right? So that's why I laughed and I said BMGF, because you can pretty much forget about funding from most other resources if you're doing rights-based work in India at this particular political moment. I think, yeah, Anandita's question is very apt. generally the research ecosystem, and this is from, you know, from I think our point of view, has been that if we are to be an important part of doing the agenda setting as we are doing now, then we need to be involved as co-producers of that knowledge and not really as co-principal investigators. I think there's a distinction, and that semantics is important. Do you want to add to it?
With regard to future research, one of the suggestions is that we have to legalize electronic health records because it will continuously generate data that you actually require to do the research. And apparently the government is trying to bring in this Ayushman Bharat Digital Health Program along with the EHR, but that's still remaining in guidelines, and it has to be legalized first. And the insurance companies, to make sure that, you know, everything is happening in a good way. To make sure that, you know, everything is happening in a good way.
For education. So for education, now the NEP allows you many to start skill-based programs. So it can start as a PPP. It can go as a blended or a virtual e-learning courses. And like we have some schemes in which we can develop this. We can develop e-learning courses, skill-based programs, initiate some skill-based courses that can be offered. Like we were talking about Catch Them Young for students, you know. So we have these electives or audit courses, 1 credit, 2 credit. So this can be in the basket of credits which anyone can take. In adult education, there are of course different schemes. So I'm only talking about the education sector.
So this is a cesarean section rate and all this is a big program. This is a big program, and we have family planning programs in India, and Commissionerate of Health, they look after these programs. Like HIV programs and funding on tuberculosis and preventing all these communicable diseases. We can make some different kind of prevention, and we can government can spend. We can request to the different yeah. Like family planning program, it was a big program. It started somewhere in 69, 71, like that. And this also, it can be, they can include it.
So I would go with a multi-stakeholder approach. One is a unilateral or a bilateral body, UNICEF, somebody who deals with women and child, you know, a funding organization like a Bill and Melinda Gates Foundation or an Access Health or, you know, Rockefeller will be.
I thought that was a really good place to end, actually, because it basically brings all the three things together, doesn't it? So thank you very much for that, the three groups we've had. So I'm sorry that was a bit chaotic in that last session there, but that's technology for you. Very useful for us, what you've all been saying. And I think one of the questions which was asked is, what's this for, and who's going to action it? We are certainly not going to action all of this. So part of the point of having this conversation with everyone in the room was to say, if anybody here wants to meet together to form maybe a research group or or an education group or whatever to take this topic forward, then we are very happy to catalyze that, if you like. But we are keen to do some research going forward from our project, but we also are very aware that really it needs to be done by people in the country. because you're the ones that understand what's going on. So this is not for us to take away and run and do some project somewhere else with. It's really, it's like a kind of gift to you all, I suppose, to say, now you've been together, what is there that you can do now taking this forward? In our meeting yesterday, somebody spontaneously said they wanted to set a WhatsApp group up so that people in the meeting could continue the conversation after the meeting. So we're going to set that group up, and we'll let everybody here know. If you want to join that group, you can. We won't manage it. It's really just for you, if you find it useful and you can take it forward. But obviously, we will be thinking about future research, specifically from the Rejudge project, and we'll let you all know about that as and when that comes up. Some people in this room are to be kept updated. Please leave us your emails, and then we will make sure that we keep you updated. And we'll to be kept updated, please leave us your emails, and then we will make sure that we keep you updated, and we'll give you the link to the WhatsApp group. Are there any other questions before we wrap up? And we do want a photograph before you all go to lunch. So, and yep.
I just want to share one thought with the group here. There was a press release made by Government of India. I can share with you offline with that, where they have identified about 12 to 13 interventions to address the issue of cesarean section in this country. You know, the law is one which I shared, and then there is a maternal and child health wings to take care of the high-risk pregnant women. So on and so forth, Laksha, there are several things. Even at the country like India, to measure what is the outcome and the impact of these interventions or the cumulative effect of that. I feel very strongly that some of those interventions are going beyond the public health sector also. That will enable us to know where we stand. So assessment, analysis, and then action that may identify certain priority clauses that they dovetail with this. Thank you.
Action in the section, then at the very minimum we need unnecessary. It should not have to go to litigation in order to then do an autopsy of what went wrong. So if there is something that we can do to campaign in reducing C-section rates in the private sector in India.
Experts, students, researchers, academicians, some of us lay, we've had a half day of great interaction. So thank you to Professor Shamanna and Geeta for bringing finally.
First and foremost, I want to thank each one of you for making said. One of you, I can't name you by a thing, and some of you are very senior members of the fraternity and also, you know, making it possible to come here. All this wouldn't have been Anna and the team, which could have been amazing. It's been an amazing, you know, 16 to 18 months of work which we have done, and in spite of COVID and all the other, they are still distributing the certificates, but they can raise their hands. Sunny? Karthik, where is Grace? She is very graceful today. Grace, yeah. Nilu, Dinesh, where's Dinesh? Raise your hands, Dinesh. And if you have, you know, Grace is here, Grace is here. Yeah. The most important person is always Mr. Shivakumar because he deals with money. So India, with the permission and with the support of my dean, Aradhana, who has one of the best handwritings, and we made sure that she comes and writes our certificates. So notwithstanding all the things which happened today, I think it's our promise to Sue and others and everybody else, in case we want to pursue this in any form, the University of Hyderabad School of Medical Sciences and our group is always going to be there, and we will sort of guidance as well. So thanks very much once again. Before we break for lunch, I think it's important that we take a group photograph here, evidence-based. Thanks very much again. If you have bills and other things to submit, taxes, claims, etc., Mr. Shivakumar is there. you can Shiv Kumar, please. Yeah. Thank you very much. Yeah.
Who didn't get the certificate, they can collect it from this.
Yeah. Certificates.
So did I steal your thunder?
No. I said we didn't have match fixing. I said. Karthik, call yours, organize us.